So we're going to start off with what should be the simplest option, a modified approach. And being aware that there's so many different ways that we can apply ketogenic therapy, I wanted to just run through really, I suppose, why we might use modified approaches, but there's a variance in the approaches that we can use. So why would we use a modified approach? Well, what we're really wanting to do is achieve seizure and symptom control by the easiest possible route. You know, if we can do it in a straightforward way, why should we bother doing it in a more complex way? But for all of us who work in ketogenic therapy, we know that sometimes, you know, a simplest way doesn't quite work, so you have to do it in a more complex way. But this is the only reason why you might do this, or you might try this approach, and then if you have to move on and use something a little bit more complex, then you can do. But you have to obviously consider your individual and whether this may be appropriate for them. And we've heard earlier on about again, different age groups, obviously infants and very young children. I know some centres do use a modified approach for very young children, but generally they are older than 2 years and teenagers and adults. Obviously, they have to be very capable of eating orally and willing to eat quite freely and have a good appetite and eat regularly. Generally, in a home setting, we found it very difficult to apply a modified approach sometimes to a multi-carer setting. So when one person is being looked after by lots of people, then that can be quite difficult because people often have to make a decision about meals time by time. So it's much easier if it's actually just in a home setting or a family setting, or it's an individual who's making the choices for themselves. In a modified approach, again, it's more choices, making decisions, and that doesn't suit everybody. Having said that, for some people, the restrictiveness of the classical approaches or the MCT approaches is just too much. And so this may be a good approach to because it may well be this or nothing. So, you know, it's a good approach. But the important thing to remember is that the dietary side of ketogenic therapy is one aspect, but the monitoring aspect is key too. And whether it's a modified approach or a classical approach or an MCT approach, the actual monitoring, as in the self-monitoring, monitoring seizures, weight, all those aspects is just the same. And you still have to have the contact with the team. So the involvement with the team is important, maybe slightly less, but sometimes it's not. So it can still require a tremendous amount of education and support and encouragement and guidance. So I wanted to, again, because I know that there's many of you who will be using modified approaches, and I think I just wanted to try and raise the issue that there are so many different ways of doing this, and the workshop that we're running is really, we're taking you and showing you one approach, one way of doing it. But there are different ways of modifying ketogenic diets. So we're going to be talking about the modified ketogenic, which we call sort of UK. It's not necessarily UK. I know they use this sort of approach elsewhere. We've got the modified Atkins diet, which has its own sort of defined protocol. The low glycemic index treatment. And I think it's important to know there are so many similarities between these, but there are also subtle differences. And so it's important to know that. Now, this is a little bit tiny for you, so I will just try and highlight the main differences. So with the MAD protocol, who uses the actual more Eric Kossoff's MAD protocol here? Anybody use the actual MAD straight? Yeah? So again, this is really, Eric's view of this is that it has to be so simple, so simple. No weighing, no measuring, really just so simple. And focusing on just controlling the carbohydrate, and everything else is much more free and easy. And also limiting the carbohydrate quite significantly in the outset. So for a child, it might be 10 grams of carbohydrate per day. Adolescents, 15. Adults, maybe 20. So that is different. Fats are encouraged and need to be included with every meal. Protein's not restricted and not specified. And in fact, it's almost a little bit more generous, really, in the MAD. Energy, again, they're encouraged to weigh and check weights, but it's not specified. and then supplementation is recommended. So that's the MAD. So again, the idea behind it was that it was really simple and very easy to do, and that has a lot of positives. The low glycemic index treatment, again, has a slightly different approach, focusing mainly on controlling blood glucose levels. So a little bit more carbohydrate, but it is a little bit more prescribed. And certainly the way that Heidi developed this in Boston, it is a little bit more guided and prescribed, and certainly protein portions, fat portions, carbohydrate portions are a little bit more controlled. But still it has the benefit of maybe having a little bit more carbohydrate present there. But that carbohydrate is controlled by the glycemic index. And so that, I personally find that complicates things a little bit more for people. So we do tend to actually use more of a modified Atkins, modified ketogenic approach, rather than using this approach. Again, the fat is about 60% of the energy prescription, protein is about 30%, and supplementation is recommended. So the modified ketogenic diet, which we call it in the UK, again, I don't think it's just the UK, I think it's used quite widely, is using elements of that relative simplicity of focus on carbohydrate predominantly, as the modified Atkins diet does. But we do encourage people to start with, maybe do some weighing and measuring just to get their eye into seeing what a portion looks like. And that's why we use the lists that we've distributed today. And we also try and ensure that that carbohydrate is distributed through the day. So who here uses a modified approach, but they maybe just give people a total for the day, and then the carbohydrate is just a total and they can put it wherever? So you do, Monica?
They have to divide.
Oh, they have to divide it. Okay, yeah. Yeah. Now, I have heard Eric Kossoff and the American team saying that, it's wherever, put it wherever you want to. And, maybe that's going to work for some people. It might, but maybe not for everybody. So we tend to encourage distribution and try to encourage them to include fat and carbohydrate and protein in each meal. So it's spread out a little bit more like the classical or MCT. And we also give them guidance on fats because people often fear fat. And I think that's the difficulty with the modified Atkins. If you just say to people, just add fat, add fat to appetite. We know that people are frightened of fat. So in some ways, it's maybe easier to give them a bit of guidance so you don't have to then pull them back. Either they've not had enough, they've had too much. It maybe just give them a bit of guidance to get them started in the right direction so they feel satiated adequately, they're not too hungry, not too full, and it just helps them to avoid problems, potential problems. Protein, we are more cautious with protein, just normal portions, but we just discourage from having large amounts of protein. And obviously energy, we base it on an energy prescription in terms of the dietitians working it, and we do recommend some base level vitamin mineral supplementation. So there are a lot of similarities there. Now, just looking at how that might work out on pie charts. Pie charts can be a little bit overwhelming when you've been through quite a lot of these things. But essentially, I think the differences to see here are that there are obviously subtle differences in the fat content. There's not a lot of difference really in the carbohydrate content between the modified Atkins and the modified ketogenic diet. Within the modified Atkins and the low glycemic index treatment, there is talk about 30% of the protein providing the calories. Well, I think for most children, they can't physically consume 30% of their calories as protein. I think it has to come from other things. If you work that out, 120 grams of protein in a 1600, if you're doing it by number, that works out to 120 grams of protein in a 1600 calorie diet. And that doesn't quite compute, I don't feel. People often don't eat that much. So I think that probably in these regimes, they end up eating a bit more fat, probably, which is absolutely fine. That's how it might work better. So that just gives you a little bit of an idea of the variances. But I would say that there is so much variance and individual variance that it actually probably is a bit misleading when you start to look very closely at them and compare them like this. So the differences and similarities, well, some centres may start the carbohydrate lower and increase it, which is a modified Atkins diet as per protocol. Start much lower, then if you're getting benefits in a month, you start to increase the carbohydrate. Some centres start a little bit higher with the carbohydrate and then they bring it down. Again, there may be some benefits in doing that to see see if you can keep it as high as possible. In the different regimes, we'll use different measurement tools, and I think you have to. It's important to try and make things as practical as possible. So visual measurement is obviously very good, but sometimes people need to do it by scales to start with, just to learn and see what it looks like. And then that means also when they're out and maybe having restaurant, trying to feed a child in a restaurant, or then they've got an idea, they know what to look for, and they can maybe do the portions perhaps without having scales at all. But you've got it in your mind. The low glycemic index treatment, of course, you've got to restrict to a certain list of LGR, the glycemic index less than 50. We give guidance on the fats with a modified ketogenic diet. So, but in terms of similarities, we know that we don't get a good ketogenic effect if there's an excess of calories going in. So fuel control, really in all ketogenic regimes, there's got to be an element of fuel control. It's no good if people are having excess calories, and it's also not ideal if they're having too few calories. So finding some way of actually monitoring that is important. They all need some degree of assessment in terms of adequacy and possibly and likely vitamin and mineral supplementation, although you don't have so much restriction over protein, so their nutrient intake often is a little bit better. And they all need monitoring and fine-tuning, absolutely all need that. It's not a case of just this is your modified Atkins or your modified ketogenic and off you go. They all need the same amount of support, really, to ensure that it's actually working and delivering. So in terms of turning those numbers, because we all work in numbers, but we've got to turn them into meals, we need to obviously focus initially on carbohydrate sources. So again, I showed some of this yesterday, so I'll go through this pretty quickly. Maybe pictorial lists can be helpful if you can get them, so that people can see what a portion will look like, and then they can translate that to their plate. Or household measures in cups. In America, they use a lot of cups. We use tablespoons, and we may use certain measures like cups. But also we tend to use choice lists quite frequently. Lots of fat sources, giving them variations in that, and portion guidance, I think, is quite helpful to start with. They may not need it for that long, but it's helpful to start with because people are fearful of fat. They need to know where the protein is coming from. We use meal planning sheets and work through with them a few meals to give them an idea of what a meal, working out a meal may look like. And we give them help to read food labels and understand. In terms of starting out, this depends on the individual and how they are managing. We have an adult team in Birmingham who actually they change one meal a week so that the adults don't get onto the full ketogenic program until about a month. And that's worked very well. And it means that they just have to think about one meal and then they're happy with that for a week, and then they go to the next meal and the next meal. So even if it has to be slow, you can still get effects. Having said that, you can still introduce these sorts of regimes very, very fast, day by day, I think most people don't introduce. How many people introduce the program just the same day, every meal change? Every meal change same day? Anybody with modified? Or, yeah? Or who suggests maybe they change one meal one day and then another meal another day and move slowly? No?
Depends on what the patient wants, so
Yeah.
we give them a choice.
Yeah. And I think that's it. It has to be at the right pace for the individual, what they want to do.